neurologist with special interest in neuro-ophthalmology. She's director at the Eye Associates Mumbai and is a consultant at Jaslok and associate prof at JJ Hospital. We have with us none other than Dr. Phiroze Patel, one of our stalwarts of Bombay Ophthalmic Association and a great teacher par excellence. Welcome, Dr. Phiroze, sir. We have with
Thank
us,
you.
Among the guest faculty, we have with us Dr. Azad Irani. Dr. Azad is a consultant, a neurologist at Jaslok Hospital. He's a fantastic clinician, and above all, I know him as a fantastic human being. So welcome, Dr. Azad.
Thank you.
I'm sure we are going to learn a lot from you today. And last but not the least is none other than Rashmin Gandhi. Dr. Rashmin, welcome. I think you need no introduction. Dr. Rashmin, I know since our Shankar Nethralaya days, he was a consultant at Shankar Nethralaya, and he was a leader of the FRCS education module in India. And also he has special interest in neuro-ophthalmology. Again, he's a fantastic clinician and a teacher. So welcome, Dr. Rashmin. And without delay, we'll start off. So, Apnesh, you want to put in any words or anything for our people who are attending today? Some quick instructions.
Yes. I would request everybody to tell their friends who are not able to log in to type their whole names. If there is any internet lag, then please log off for a minute and a half, and then please re-log in and try to keep your mics mute all the time. You can type your questions in the chat box if at all you have. So we can start.
Do it for me, na? Share screen. Give me 2 seconds. Huh? Okay. So can you hear me?
Yep.
Okay. So thank you, BOA, for giving me this opportunity. And today's topic is approach to disc edema, interesting cases. So if you see this first slide, you see 4 pictures of disc edema. All the 4 pictures are showing different types of disc edema, but looking at the pictures, one cannot make a diagnosis. So hence, the reason why I'm sharing this slide is to emphasize to you the point that disc edema is a sign and not a diagnosis. So how does then one diagnose disc edema? So as usual, in any neuro-ophthalmology topic, the history is most important. Look at the onset of the vision loss, gradual versus sudden. Presence of any preceding symptoms like nausea, vomiting, tinnitus, TOVs, etc. Whether the disc edema is unilateral or bilateral, whether the onset of vision loss is associated with pain or without pain. For example, a gradual painless loss of vision would point towards an ischemic optic neuropathy, whereas a painful loss of vision could point towards an optic neuritis. Goes without saying that the history has to be accompanied with a good neuro-ophthalmology examination. So a special mention for the pupils, the extraocular movements, and the color vision. When I talk about color vision, I remembered an interesting case which I recently saw in my practice. So this was a young boy who had decreased vision in the right eye. He had disc edema in the right eye. And when the left eye was normal, I checked the color vision in the right eye, and the color vision was, he was not able to identify all the plates. But I checked the color vision in the left eye, and the left eye also, although being normal, he was not able to identify the colors. And then when I asked a detailed history, he said, you know, ma'am, I've always had a little difficulty with colors as a child, and I think my father is colorblind. So that is something that you need to keep in mind as well. Every patient of neuro-ophthalmology, I advise perimetry, and the choice of investigation here is 30-2 automated perimetry. Now, a lot of times, the vision may be poor, but I would still insist on perimetry in the other eye. I would still insist a perimetry for the other eye, because sometimes that may show up a vertical field defect, which may immediately point towards an intracranial cause. And then neuroimaging has to be done in some cases, lumbar puncture in selective cases to document the opening pressure of the CSF, and microscopy. So here are some good examination tips. The first thing is don't dilate your pupils till you've determined the presence of RAPD. And most of us don't see the patients initially, and hence you have to train your optometrist to do the same. Second thing is always, when you're looking at the fundus, compare the fundus with the fellow eye. Pay attention to the perimeter of the disc, looking at retinal nerve fiber layer opacification and obscuration of the retinal vessels over the disc margin. And always assess the patient's neurological examination, and don't forget to test the relevant cranial nerves. So that comes to an important question. What is the difference between papilledema and disc edema? So papilledema is a term which is very loosely used by all. And one needs to understand that papilledema is swelling of the disc secondary to a raised intracranial pressure, whereas disc edema is any other cause of swelling of the disc other than raised intracranial pressure. Pseudopapilledema is another term that you need to keep in mind, which means an anomalously elevated disc. This is not a true swelling. Note, an atrophic disc will not swell. How does one differentiate between pseudopapilledema and papilledema? Well, this is a textbook picture, but the important point here is venous pulsations. Remember that 20% of the normal population will have absence of venous pulsations. So therefore, venous pulsations is not a sure shot sign. Look for presence or absence of hemorrhages and exudates, and look at the disc vessels at the margins of the disc. Of course, these two have to be accompanied by your perimetry. So this is another slide showing you pseudopapilledema versus disc edema. So this is a myelinated nerve fiber, pseudopapilledema appearance. This is a hyperopic disc, crowded disc. This is a true disc edema. This is a disc edema with blurring of the disc margins and lots of hemorrhages and exudates. So what are the causes of pseudopapilledema? Again, very simple. Myelinated nerve fibers and hyperopic discs, optic disc drusen's we commonly see in our practice. Apart from that, persistent hyaloid tissue. This is for the benefit of the postgraduates. What are the causes of raised intracranial pressure? So I remember the 6 M's: mass, space occupying lesions, malignant hypertension, medications, mucked up drainage, morbid obesity, and meningitis. So typical features of papilledema: it is usually bilateral but asymmetric. The optic nerve function is preserved in spite of florid disc edema. That means that even if you may see a very angry looking disc, the vision will still be relatively good. Papilledema may also be associated with lateral rectus palsy, and in this case, the lateral rectus palsy is a false localizing sign. Depending on the cause, other neurological symptoms may be present, and the color vision in papilledema cases is usually not affected. So just running through these stages of disc edema, this is the early stage of disc edema. You see a splinter hemorrhage here, blurring of the disc margins. And then that progresses to an angry looking disc, classically described in the textbooks as champagne cork appearance. The cup is obliterated, lots of hemorrhages and telangiectatic vessels. And then finally, an optic atrophy sets in. The disc becomes pale, the retinal vessels become narrow, sheathed, and the exudates and hemorrhages disappear. And atrophic changes occur within several weeks and even days, depending upon the intracranial pressure. So what is the workup of papilledema? Again, to remind the people who've joined late, papilledema is a term used to describe disc edema secondary to a raised intracranial pressure. So when I suspect a papilledema, I'm going to perform an MRI. Note, CT has no role when you're looking at a disc edema. The choice of investigation is MRI. If the MRI is normal, don't stop. Do an MRI venogram because you want to rule out a venous thrombosis. If your MRI venogram is normal, go ahead and do a lumbar puncture. Lumbar puncture, if the opening pressure is high with a normal MRI and an MRI venogram, your diagnosis is benign intracranial hypertension. When you're doing the LP, don't forget to document the opening pressure and send the CSF for microscopy and biochemistry. Bilateral cases, always measure the BP. And always check the intake of any drugs like vitamin A, tetracyclines, oral contraceptive pills, etc. What is the role of OCT? So OCT is a popular tool that all of us have in our OPDs. And the role of OCT, it helps to diagnose an early disc edema. In such cases, the RNFL thickness is found to be increased. The OCT not only helps to diagnose an early disc edema, but it also helps to differentiate a true disc edema from a pseudopapilledema, and thus saving unnecessary investigations. There was a study which was published in Ophthalmology 2011, which demonstrated the role of spectral domain OCT for direct visualization of the optic nerve head drusen. So with this background, let me begin with some interesting cases. The first case is an example of an acute unilateral loss of vision without pain. So this was a 65-year-old male. He complained of gradual loss of vision noticed in the right eye. He gave a medical history of diabetes and hypertension for years on together. His vision in the right eye was 6/6 and in the left eye it was 6/18. The pupils clearly showed an RAPD. The color vision was normal in both the eyes, and the fields revealed an inferior altitudinal defect. So loss of vision, diabetes, inferior altitudinal defect, and the fundus, which looked like this, corresponding field defect, is suggestive of an ischemic optic neuropathy. So in such cases, there's no role of neuroimaging. What's the role of steroids? It's controversial and yet popular, and the dose that is recommended based on high-rays study is a high dose of 1 milligram per kg body weight if seen within 2 weeks of onset. Is there any role of IV-MP? I would think not. High doses of oral steroids are as good as IV-MP, and hence the IV methylprednisolone is not required in ischemic optic neuropathies. What's the rationale of giving oral corticosteroids? The steroids help in reducing the capillary permeability, thereby decreasing the vasogenic edema, which has set up a tight compartment syndrome. And hence, by relieving the tight compartment syndrome, it helps in improving the function of the surviving hypoxic axons. So then, should steroids be given to all patients with ischemic optic neuropathy? Which patients do I offer steroid therapy? The ones that have a severe visual loss, the ones who are one-eyed and have presented within 2 weeks of presentation. However, a word of caution is to dissuade steroids in patients prone to high risk of side effects from steroids. My current protocol is that if I see or come across any patient more than 50 or 55 years of age with an ischemic optic neuropathy, I definitely want to rule out giant cell arteritis by testing the ESR and the CRP. If the presentation has been earlier than 2 weeks, then I offer steroids to this patient. I always like to give aspirin and anticoagulants to these patients, as the current belief is that all ischemic optic neuropathy patients are at a risk of stroke. And hence, if there's no systemic contraindication, then I definitely offer aspirin and anticoagulants. One has to tell these patients to go back to their physicians and control the vasculopathic risk factors with special attention to minimizing the dose of the antihypertensives at night and monitoring the cholesterol. Do not forget to ask for symptoms of sleep apnea. Today, sleep apnea is a very big contributory cause for ischemic optic neuropathy. And the latest news surrounding ischemic optic neuropathy was that the QUARK trial has been discontinued. Now, QUARK was a intravitreal injection, which was being given for ischemic optic neuropathy, and that has been discontinued. The second case is an example of bilateral vision loss with headache. So this was a young 13-year-old girl. She came to us with complaints of sudden onset squinting with diplopia and headache. As you see in this picture, there is a left convergent squint. And I don't have a picture to show you a defective abduction, but she did have a left lateral rectus palsy. Her vision was 6/9 in both the eyes. There was no significant refractive error, and the fundus, to my surprise, revealed bilateral disc edema. So what do we have? A lateral rectus palsy with bilateral disc edema. The lateral rectus palsy here is obviously a false localizing sign. So we ordered an MRI for this patient, which was normal. And then since the MRI was normal, we went ahead and did the MRI venogram, which was suggestive of a sinus venous thrombosis. This patient was then referred to neurology for further treatment, and post-treatment, her eyes are straight. So the take-home message here is that in any case of papilledema, if the MRI is normal, don't stop, go ahead and perform the MRI venogram, not angiogram, but MRI venogram to rule out a sinus venous thrombosis. The third case is that of a 12-year-old boy. This was a boy who's been my patient for a very long time. He's been following up with me for refractive error. And this time when he came, his main complaints were that I'm seeing black spots in front of my right eye. The vision with glasses was 6/9 in both the eyes, and refraction showed a mild cycloplegic change. And I was about to prescribe the prescription, and then I said, let me look at the fundus. On seeing the fundus, there was bilateral disc edema in both the eyes. The child was cooperative, so the next step was perimetry, which showed an increase in the blind spot. So we have a 12-year-old who complained of black spots in front of the right eye with bilateral disc edema on examination with correspondingly increase in the blind spot. So disc edema with increase in the blind spot points towards papilledema, which means that the intracranial pressure was high. So what are the differentials that are going on in my mind? Could this child be having a space-occupying lesion? Could he be having a venous sinus thrombosis? Am I looking at an inflammatory cause? Or is this idiopathic benign intracranial hypertension? So we went ahead and did the MRI. Since the MRI was normal, I went ahead and did the MRI venogram. And surprisingly, even this was normal. So now I've ruled out space-occupying lesions. I've ruled out a sinus venous thrombosis. Next thing I want to rule out, am I looking at inflammatory cause? So this was the workup that we did for the patient, and all was normal. So now, it was with great difficulty, I convinced the patient's mother to let the child undergo a lumbar puncture. And on lumbar puncture, we found the opening pressure of the CSF to be very high, about 580 millimeters of water, and the CSF analysis was normal, and hence a diagnosis of benign intracranial hypertension was established. But the dilemma was that what caused a benign intracranial hypertension in this young 12-year-old who was not obese? So we went back to taking a detailed history from the mother, and on questioning and questioning again, she, by the way, very casually mentioned that, you know what, my child has been on this drug called fluvoxamine for the last 2 years, and he's been taking about 100 milligrams a day. The reason why he was prescribed this drug by a psychiatrist was for his obsessive compulsive disorder. Later on, we read up about fluvoxamine and found it to be a serotonin reuptake inhibitor commonly prescribed for OCD and even depression. But one of the rarest side effects of this drug is benign intracranial hypertension. And this was a case report which I published in 2018 in IGO. The treatment here was simple. The drug was discontinued and the child was treated with Diamox. The BIH resolved in due course of time. So the take-home message here was that do not forget a fundus examination, even if the patient has come for a simple refraction. The next case is an example of acute unilateral loss of vision without pain. So this is a 16-year-old young male, otherwise healthy, complains of sudden painless loss of vision. His vision in the right eye was 624. Pupils elicited a clear RAPD in the right eye. The color vision was mildly reduced and the perimetry showed a secocentral defect. So we have a disc edema with a macular star-like appearance with the secocentral defect points towards neuroretinitis. So a characteristic star figure in neuroretinitis takes at least 9 to 12 days to develop, and hence very commonly these patients are mistaken for an optic neuritis. Please note that neuroretinitis is never associated with demyelination. The magnitude of vision loss in some of these patients is out of proportion to the RAPD, and this could be a significant clue pointing you towards neuroretinitis and not an optic neuritis. The vision loss here is because of both eyes maculopathy despite prominent disc swelling. The commonest cause in our country is TB, syphilis, sarcoid, or toxo. And the commonest field defect that we come across is centrocecal scotoma. Please note, again, in these cases, there is no role of neuroimaging. How do you treat these patients? With suitable antibiotics, and steroids are to be introduced in appropriate cases. Visual prognosis is excellent. The fifth case was a difficult case, which I just saw before the lockdown, and hence I call it disc edema in COVID times. So this was a 28-year-old girl. She was high hyperopic plus 6 spherical in both the eyes. And her main complaint was that, doc, I'm seeing a veil in front of the right eye and I'm having a little difficulty focusing, particularly for near. She also gave me history saying that as a child, she had been diagnosed to have a lazy eye in the right eye and that she was aware that her vision in the right eye was slightly less as compared to the left eye. On examining her, her vision currently was 612 in the right eye and in the left eye it was 6.6. The color vision, both eyes were normal. The pupils were reacting to light and there was no clear RAPD. Her general health was very good. There was no headache, tinnitus. She was of a moderate build. She had a great appetite, no fever, nothing. This was her fundus picture, both eyes elevated discs. And you see the central hyperemia here, blurring of the disc margins and slightly dilated vessels. But at some points, I felt that the margins of the vessels were clearly seen at this point. So we went ahead and did the perimetry. In the right eye, we found these kind of defects, but the false negative here was 40%. So this field was not reliable. Whereas this left eye to me looked normal. So now what am I thinking? Am I looking at a papilledema or am I looking at a disc edema? Could this be a large drusen of the optic disc, which could be contributing to a pseudopapilledema appearance? She was also a hyperope, which could be another contributory factor. So essentially, I was thinking more in favor of pseudopapilledema, as most importantly, that the patient was asymptomatic. We got a B scan done, and the B scan reported a bilateral elevated disc with bilateral dense optic disc drusens. Now, to be safe medico-legally, and since I hadn't seen the patient again, all the images were shown to me on WhatsApp, I decided to go ahead and do a CT scan to confirm the presence of drusen. But strangely, the CT scan did not make any mention or absence or presence or absence of drusen. In fact, it said no evidence of radio-opaque foreign body seen. And, it also mentioned bilateral prominence of the optic nerve sheath complex with a partially empty sella and a mucosal thickening on the right maxillary sinus. Because there was no mention of the drusen, and this me, in spite of asking the radiologist to specifically look for, this added to the confusion. What if I was dealing with a true papilledema? So I decided to go ahead and do the MRI and also the MRI venogram, thinking that that would give me a clear picture as to what I'm looking at. So we go ahead and do the MRI and the MRI venogram, and this added to the confusion. The MRI venogram mentioned that there was loss of the normal flow related signal in the left transverse sinus with left sigmoid and left internal jugular vein appearing hypoplastic, but the right-sided transverse and sigmoid sinuses were normal in course and caliber. Patient's main complaint was on the right side. The elevation of the disc was more on the right side, but the MRI failed to mention anything abnormal on the right side. The CT scan mentioned empty sella, but the MRI brain did not mention anything about an empty sella. There were no dilated ventricles that were documented in this MRI. So now the confusion. B scan says dense drusen, CT scan fails to mention about the drusen, MRI is normal, and the venogram mentions changes on the left side, but the patient's symptoms are on the right side. And in fact, the MRI venogram advised to correlate with a CT venogram, which was pretty strange because MRI venogram is more sensitive in picking up venous sinus thrombosis as compared to a CT venogram. So the final diagnosis after discussing with the neurologist, we thought was a disc drusen, which was causing more of a pseudopapilledema kind of appearance. There's a small possibility that this disc drusen may have caused an ischemic optic neuropathy in this patient, and that's the reason why the patient complained of a wale that she was seeing inferiorly. Unfortunately, because of the lockdown, we could not perform an LP in this patient. However, it's been 3 weeks. The patient is stable. She does not complain of any headache, no further loss of vision, no complaints of tinnitus, no double vision. So essentially, her condition has not progressed. So this is how I managed a disc edema in COVID times. And this case also highlights the importance of good communication between an ophthalmologist and a radiologist. So the take-home message from this presentation is that in every patient of disc edema, you must perform the visual fields whenever possible. Not every patient with disc edema needs neuroimaging, but every papilledema needs one. Not all disc edemas respond to steroids. Beware of pseudopapilledema, and papilledema is a true emergency requiring an urgent workup. Thank you.
Sure. What I would do in the first week, in especially patients who are having a lot of comorbid situations with them, would be to give a peribulbar or what we call a deep anterior bulbar steroid, long-acting steroid. because, as you correctly said, that diabetes, hypertension, they're usually in one kidney, and so many other renal issues, that this also tends to help, of course, without us, getting into any medical issues. But because starting steroids often causes complications, as you very correctly mentioned.
Good point, sir. Have you observed a good response to it?
Yes, but 50-50, Rashmin, 50-50. Those who we haven't given anything also have improved, and those who we've given. So we never know, but at least sometimes people feel a little pacified if we gave them the peribulbar injection.
Yes.
Any other questions, Rashmin?
Yeah. So there is some discussion of saying that give IV methylprednisolone on day 1, and then Dr. Preeti has mentioned, and then give oral steroids. Well, I don't have experience with that, saying that, okay, give only 1 IV dose and then give oral steroids. But it sounds logical, but I really don't. I've never used it, and I don't know whether you, Phiroze sir, or Dr. Azad has any experience saying give 1 IV and then give oral steroids. She has based on her hypothesis on the pharmacological, saying that if you give 1 IV, then probably you will reduce the chances of side effects.
It's something to think about, but I haven't, generally I don't use IVMP. I'm good with oral steroids. And even if I have a diabetic patient, I counsel them well and then refer them to their physician, and then we coordinate and we start the steroids.
And in fact, Rita madam has mentioned that, is it possible to do maculosity? In fact, there was a paper by a group from Boston, Thomas Hedges and his group, who actually had shown this presence of macular fluid. They did maculosity in all the patients that they saw with anti-ischemic optic neuropathy, and they did demonstrate that there is a macular fluid. I have not been doing maculosity regularly for all these patients because I'm not going to do much about it, but that's a good thought as well.
So let's move on to that BIH case. There's a question here that Azad, you can probably tell us how to titrate the dose of Dimox for IH.
Yeah. So again, theoretically and practically, theoretically books will say start with 500 mg of Dimox in a day. That's 250 divided twice, and you can go up to a maximum dose of 4 grams. However, practically speaking, in the Indian scenario, we almost always start with 250 half twice a day, because patients have lots of side effects of tingling, numbness, etc. And then we slowly move up. And almost never have we ever used more than 1500. Even 1500 is very rare. So start slowly, half BD, look for side effects like tingling, numbness. Even if the patient says that, ask them to hydrate well, take adequate salt intake, and then slowly step up the dose. Of course, every 2 weeks or 3 weeks, monitor the other findings, and if needed, then go up despite side effects.
Yeah, in fact, very recently I had a patient where he developed raised intracranial pressure as a side effect of the medications that he was taking for ulcerative colitis. And it was a very tricky situation because his colon was very bad. He was suffering because of that. And then he started losing vision because his nerves were getting swollen very fast and the neurons were dying. So we had to straight away start 2 grams because otherwise he was not fit for any other surgery as well. So we had to go high right in the beginning and be titrated with his general condition. We could salvage one optic nerve, the other optic nerve actually went into pallor. The one way our role, I mean, what Dr. Azad said is absolutely right. And generally, I involve neurologists straight away when I see a patient with a raised intracranial pressure, and I let him monitor the treatment and other aspect of the pressure. Our role generally would be to guide and tell neurologists as to how the optic nerves are behaving. And the way I do it generally is visual acuity, color vision, pupil, visual fields, even OCT. initial period when we start the treatment, serial OCT does have a role as to, how the swelling is behaving, whether it's going down very fast, or whether there's a steep, or whether there's a slow decline in the swelling, or there is an increase in average RNFL swelling, because that would tell you as to how the optic nerves and the intraocular pressures are behaving.
What about the visual fields? There's a question here that in IIH patients, how frequently will you repeat the visual fields and OCT? So I think you would repeat the OCT frequently, but I don't think I repeat the visual fields very frequently. I mean, after...
Yes, I agree with you. And only scenario where I would probably do visual field more than, let's say, at every visit, every third day, every fourth day, is when patient continues to have complaints. And now if patient has come with headache and he says that it's symptomatically better, or patient came with a visual problems and says that his vision is little better. But if patient continues to complain about the vision or any other symptoms, I know that we are not very sure whether the intraocular pressure is really going down, whether our treatment is having an impact. And that's where I would also take into account the visual fields. What I look at in visual field is the grayscale and see if the blind spot size is showing any visual impression, is any difference. And I also look at mean deviation and see if there is a significant change in mean deviation. If there is a change in mean deviation, you know that probably you would like to get the treatment higher. Phiroze sir, would you like to add something here?
I was just wanted to ask, especially regarding this visual field that you mentioned, Rashmin, that would you advise the smaller visual field test, or would you advise the 120-point full test for many of these neurological cases? It's tiresome to do that, but what is your thought process?
So I would advise 24-2 if I'm just following up the patients in an acute phase of, let's say, raised intraocular pressure. Because in a raised intraocular pressure in an acute phase, I know that what I'm looking at is going to be around the optic nerve and enlarged blind spot. The chronic papilledemas are different, because chronic papilledema generally causes a tubular vision. Generally, there is a constriction of visual field. So there I would like to go at 30-2 or even higher if patient complains that he's not very comfortable with the side vision, and 30-2 comes back normal. Now, any other optic neuropathy, that is optic neuritis, ischemic optic neuropathy, I know that visual field is likely to be around the blind spot and the central yes. Visual field, and that's where I would be okay with a smaller field, even 24-2 or 30-2. In cases where I've advised visual field not knowing what the patient is having, that happens a lot of times, whether whether patient has a visual pathway disorder, whether is there really an optic neuropathy because nerves are fine and there is a trace RAPD, what's going on, is where I may start with 30-2 and go to 120-2 if I don't find anything, or if the patient keeps complaining that he's not comfortable with the side vision and I don't find anything in the usual programs.
There's a question for Dr. Azad coming back to IIH. Dr. Azad, how long to give the Diamox is the first question in IIH. And second is, how frequently do you repeat the LP in these patients? When do you decide that this patient requires shunting?
Okay, so a lot depends on the symptoms. Let me first come to how long do we continue Diamox. Now, like we know, one thing is very important. IIH is very, very closely linked to obesity. So the patient has to be told by every possible means to lose weight. So much so that bariatric surgery is very much a part of IIH treatment. So losing weight is very important. I think if the patient can successfully lose weight, we can not worry about the Diamox and just stop it whenever we want after the patient has lost weight. Even if they lose approximately 5 to 10% of weight, we can start thinking of tapering the Diamox. Let's say that's not the case. Generally, most people try to give it a break or taper it down after 1 year, but there's no guidelines. Coming to the point
of the shunting, then I mean,
yeah. So the second point, yeah. So that depends how rough the course has been. If the patient has really not responded to Diamox, then we will obviously re-image them. We'll keep checking the fundus. We'll repeat a CSF, and if we realize that Diamox, even if I mean, in most Indian patients, if at 1.5 grams, or let's say we go up to 2 grams, it's not working, we'll probably try a low dose of Lasix to add to it. And if that doesn't work, then obviously we start counseling the patient regarding surgery.
Okay, so what I've always understood is that, you know, when I see a benign intracranial patient, there are two things that I always keep in mind, the two symptoms. One is headache and the second is vision. So if the patient has continuous headaches in spite of the Diamox, then that patient is a good candidate for a shunt surgery. Whereas if the vision is progressively decreasing in spite of the Diamox, then that patient is a good candidate for an optic nerve decompression. What would you say, Rashmin?
Absolutely, absolutely. So headache, your intervention is because of headache. Generally, you would tend more towards shunt. If it's because of rapidly progressive vision or optic nerve function, you would go for optic nerve sheath fenestration. A word about fenestration. There were times where there were a lot of groups who were doing fenestration very aggressively. So even if the vision had gone down from 6.6 to 6.12 or 6.9, they would advocate fenestration, and in good hands it works well. It does bring the pressure down, but you have to remember that it has a side effect. It can cause CRAO and optic nerve dysfunction, optic nerve injury. And also you have to remember that the opening that you create in the sheath tends to, it's like a trabeculectomy scar. So it can scar down, and patient can have again a rebound impact on the optic nerve. So these are the things that we have to keep in mind when a fenestration is advised. The other thing is, a lot of times, even if you make a nick in one optic nerve, you would say that you would see that the swelling in around both the optic nerve comes down.
Rashmin, what is the success rate of this surgery?
I think it depends upon a lot of factors. What stage, number one. Number two, whether the surgeon is really proficient enough to go in and make an adequate size nick, and what was the optic nerve status to begin with. Now, I'm not really aware of any large study coming in. The study was done for AION, that was called ION-DT, Ischemic optic neuropathy decompression trial. That didn't go too well. They actually abandoned the trial and said that fenestration is not advisable, especially for AION. I have seen patients, quite a few patients. There are groups in Bangalore who do this. Dr. Jyoti Matalia from Narayan Netralaya is quite proficient at fenestration. I've seen some of her results and they're quite fantastic. Dr. Bhattu was a proponent of fenestration again in Bangalore quite some time. His results I have seen and they're quite good. So it does arrest. It definitely give you an immediate impact, and the neurons would survive if you do it well. But what is the long-term impact? We are not very sure. It would scar down.
And like you said, with a certain amount of risk. You to kind of weigh the risk-benefit ratio and then decide whether you really want to go in for an ONSD.
Absolutely. And generally, if there is a bilateral disc edema, that's what we would expect in papilledema, then you end up doing on a worse eye. So you say that when you put a nick on a worse eye, you will have the pressure down, and pressure will go down around both the optic nerve sheath. So even if there is a local complication, you are still preserving the better eye.
There's a question for Azad, again related to IIH. From, is there any role of topiramate?
Yeah, very much. In fact, that's a very good drug. So I just in fact wanted to intervene and tell you all that we were discussing when to operate. Remember, if patient has had multiple symptoms and all of them improve, but headache stays, please consider that this headache might actually be something else. Migraine is associated with 30% of cases in this particular patient population. So keep that in mind. Now, topiramate has a dual action. It's the brother of acetazolamide, so it reduces formation of CSF, and at the same time, it's the #1 first-line anti-migraine drug. So topiramate can do two things. Very good drug. Only thing is, we will be little confused as to what did we actually treat. Did we treat IIH or did we treat migraine?
Also, one other thing is that, word of caution when you're starting topiramate, you have to, baseline check the angles and document everything, because topiramate is very famously known to cause an
Yes.
active glaucoma.
Correct.
So that is something that you have to keep in mind. There's a question saying, is there any role of anti-VEGFs in ischemic optic neuropathy, Rashmin?
No, and I also saw in chat somewhere somebody had also asked about IVTA. So please remember, there were a lot of observational studies, and there were studies which are done for intravitreal injections in ischemic optic neuropathy. There has been a feeling that when you give anti-VEGF, the disc swelling goes down much faster than otherwise, but it does not alter the ultimate recovery, as in the visual field improvement and the visual acuity improvement. Now, conversely, you said that, okay, if you are able to get the disc edema faster, if you are able to reduce disc edema faster, why not then give it? But then the problem is, some of the anti-VEGF have or used to have CNS side effects, number one. Number two, AION is the disease where there is an imbalance of pressure, and there are pressures, the pressures which are in play are intraocular pressure, blood pressure, and intracranial pressure. Now, when you inject in the vitreous cavity, there is a momentary rise or a sustained rise of intraocular pressure, and there is always a theoretical or even a known risk that you would induce ischemic optic neuropathy, and that's the reason why I don't advocate intravitreal either tricot or anti-VEGF.
I think there have also been papers which have proven that giving the intravitreal anti-VEGF itself has caused an AION in a couple of case series. So in most of the neuro-ophthalmology meetings that we attend, it is very, very loudly echoed that please do not give VEGFs. Even if the patient's losing vision, that's not an indication to give VEGFs. How would counsel, it's very difficult to counsel ischemic optic neuropathy patients with progressive visual loss. How do you counsel them?
So there are a couple of issues here. One is AION with a progressive vision loss. So if you say that there is non-arthritic anti-ischemic optic neuropathy, it generally would have a vision loss and it would settle down very quickly. It will settle down at that level within few days, and then if at all, it will improve after 3 or 4 or 5 or 6 months. Now, if you say that patient has had an acute episode of vision loss and vision is now still dropping after 3 days, after a week, after 5 days, after 7 days, it definitely calls for renal function test. So patients who have a non-arthritic anti-ischemic optic neuropathy and have a progressive loss of vision, I would do neuroimaging if I have not done it already, because I might have to revisit my first impression, because non-arthritic anti-ischemic optic neuropathy generally does not cause a progressive loss of vision. So I will do neuroimaging, and I also go for renal function test. Now, how to counsel these patients, non-arthritic AION? Now, typically what I've started doing is, anybody below the age of 45, I ask for serum homocysteine. Everybody, almost everybody, I would ask for sleep study. I would also make sure that they are not smoking. I would ask for, in a male patient, I will counsel them not to take erectile dysfunction drugs if they are taking. And also if they are on amiodarone, then I'll ask them to substitute these, because these are a known risk factors or association with non-arthritic anti-ischemic optic neuropathy. Sleep study, there is a good significant number of patients seem to have associated mild to moderate to severe obstructive sleep apnea, and they would benefit by undergoing treatment for obstructive sleep apnea. You may or may not do anything for the affected nerve, but I'm sure the risk for developing AION in the other nerve you have minimized. And the other way of counseling, of course, is that this is like stroke. So we would see what happens after 3 to 6 months, because 1/3 to little more would improve by then. And what happens generally is that even if patient does not improve, there is a little bit of, if it's a unilateral problem and if the field effect is not very severe, they would get used to it, especially somebody who has mainly a superior defect. They generally tend to be happier than somebody who has an inferior orbital defect.
Rashmin, you mentioned about some of the things that you've been doing for their patients about 45 years of age. I've also been adding carotid Doppler studies to my investigation list. Documenting the carotid Dopplers on both sides. And recently we attended a neuro-ophthalmology meeting together where they said that every ischemic optic neuropathy can predispose the patient to a stroke later on. So,
yes,
Rashmin and Dr. Azad, would you do an MRI angio in all these patients?
Yeah.
You would do an
Yes.
MRI angio? Rashmin,
Yes.
what about you?
Most likely, yeah. It's an embolus that has come from somewhere. So 100% yes.
What is your thought process, Rashmin? Would you do an MRI angio for these patients?
I've still not started doing, but I know that Nancy Newman and Valerie Bewes changed our thought process, and they said that in their organization at Emory and a lot of other places, they immediately activate a stroke protocol. I had a chat with my neurology group here with whom we deal, and they were saying that they generally would not activate it in everybody and would go on a case-to-case basis. So I have not still started advising this for everybody, but I rather take my neurologist into a team to see that where is it going.
Question, and I think it's a very common question that all of us encounter, a common dilemma, is that how does one differentiate between a diabetic papillopathy versus diabetic non-ischemic, versus diabetic non-arthritic AION?
Yeah, so the papillopathy generally would not have, most of the time papillopathy would be seen in much younger patient than NAION most of the time. They would not have a predominant visual symptom unless it also has an associated macular edema related to diabetes, and many of these patients are on insulin. Versus a non-arthritic AION where there is always an acute event. In most instances, there is an acute event for which patient has come to you. So if the patient has come to you with an acute event, acute loss of vision, and if you find a significant visual field defect, that is the ortitudinal defect in most instances, then this is, and that's how you say that this is non-arthritic AION, versus papillopathy where majority of the patients would not have come to you with an acute event. He would be for the follow-up of the problem of diabetes and retina problem, and you will find during that he has developed a disc edema. Most of the time there is no acute event as far as the visual acuity is concerned, and if you do visual field, you will not find those typical field defects.
Okay. There is a question, it's a very general question, that in what conditions do you advise lumbar puncture and CSF analysis, or do you leave this decision to neurophysicians?
So now let me give my perspective, and then we'll hear from Dr. Azad and Dr. Phiroze as well. That let's say patient who, let's say we talk about optic neuropathy, and you're seeing a patient with optic neuropathy where you were suspecting inflammation or infection and not really ischemia. So you are suspecting inflammation, and inflammation can be an immune event or it can be because of infection. Now in these patients where you are suspecting an inflammation, where you are suspecting either it was autoimmune event or it was an infection, and patient has a very poor vision, patient has an associated ocular motility problem or has a progressive loss of vision despite whatever you're doing, is where I'll surely ask for LP to find out is there anything which is circulating in the cerebrospinal fluid. We have seen patients with leukemia causing infiltrative optic neuropathy with a rapidly progressive loss of vision discovered by doing blood test and also cerebrospinal fluid. We have also had a patient who had actually infection, fungal infection, which was initially treated as idiopathic optic neuritis, but then was discovered, the infection was discovered when the lumbar puncture was done. Now, in the event of obviously papilledema, you would require a lumbar puncture. Now, the textbooks teaching would be that if there is a papilledema, LP is contraindicated. Now, we need to qualify this statement. If there is a papilledema because of a clear-cut structural lesion, there is papilledema, you advise neuroimaging, you find a brain tumor, you don't require LP at that time, or maybe LP might do harm because there can be brainstem herniation. But there is a papilledema and neuroimaging is not showing any structural lesion, then you would require a lumbar puncture to find out what is the opening pressure to confirm the diagnosis of raised ICP and whatnot. Dr. Phiroze and Dr. Azad?
Rashmin, my take on this is that when I see disc edema, you see, my first thought goes to the eye. After that will go behind to the optic nerve. The third will be the intracranial cavity. And the fourth will be the systemic body. You see, very often in these multi-speciality hospitals where we practice, we find that, you know, there is often a cause of disc edema related with systemic causes, and that will include a lot of blood dyscrasias, etc., and other, you know, as you mentioned, fungal, and we are taken very much by surprise with all these sort of associations. So keeping in mind, this is my sort of thinking, which I always have when I'm first time seeing a patient. Then the eye, the nerve, the intracranial cavity, and my eyes will be certainly on the physical body wholesale to understand if something else is going on somewhere. Because by the time we start moving ahead with all the tests and investigations, there may be something else wrong also.
Beautifully put, sir.
Yeah, Rashmin, what about, we're running out of time, so let's discuss the last case. What is your opinion on that last case that I discussed? You know, it's really tricky to have this drusen and, you know, like to differentiate. I mean, look at the kind of elevation that I saw with confusing reports of CT not mentioning, B-scan mentioning drusen, CT not mentioning, MRI showing something on the left side, patient symptoms are on the right side, no comments, no dilated ventricles. So what is your take on
Hema, you were thinking of optic nerve head drusen, right?
Yes. Yes.
Now, where did you see this patient? In your private clinic?
Yes.
I would have used the OCT and done an optic nerve head imaging there.
I did.
You did? Because very often you will see small calcifications over there on the optic nerve head. And the other thing is, when we tell a radiologist, very often our radiologist friends sometimes are a little underprepared on some of our ophthalmic words, and mentioning calcification of the optic nerve head, I think, improves their functioning a little better at times.
Maybe. Yeah. What about you, Rashmin?
So only thing which is not fitting your puzzle is CT scan. Everything else is pointing towards drusen. You see, remember, even the visual field, you found that little defect in the right eye, I think. So drusen can produce a visual field defect either by direct compression of the adjacent nerve or by ischemia.
Yeah.
So to me, of course I couldn't see the disc very well, but to me it seems to be behaving like optic nerve drusen. And I would do what you have done. I mean, if you're not very sure, get the patient back and do the serial testing to see if any of the parameters are changing. If the parameters are changing, then maybe you're dealing with something which is causing axonal swelling. Otherwise, it is drusen, and we'll just sort of observe.
What about you, Azad? You want to tell how we went about thinking about this case?
So the reason we tried to just hold on and observe was because it was the COVID times. Normally we would have done a CSF, because if we are not getting an answer or if there's confusion, then that's the last step, simple as that. But since it was a COVID time, since this patient was really almost asymptomatic or slowly progressing, we thought, let's just wait for a few weeks. Let's see if something turns up. If the vision worsens, okay, fine, we'll go ahead. Or else we just wait, observe the symptoms, and then repeat an MR venogram and the OCT.
And what about the fact that the radiologist has asked for a CT venogram after having done an MRI venogram? I mean, it makes no sense.
No, it doesn't.
It's more sensitive for a venous. I mean,
it doesn't make sense.
So that, I think that case highlighted, a lot of miscommunication, guess because of these, different times. But I spoke to one radiologist, the other radiologist did the reporting. It was done in a charitable place. I don't know the quality of the images. I haven't seen the images myself. So lots of problems in, during these times.
COVID times.
Yeah. There's a question here that how long does it take for the ocular signs in papilledema and symptoms, diplopia, color vision, whatever, etc., to resolve after intracranial space-occupying lesion has been removed? Choroid plexus tumor to be specific. Azad, you want to take that question?
No, I won't have any experience, but generally we ask for a repeat fundus after 3 months.
Rashmin?
But I don't know.
No, I think it would depend upon the size of the tumor, how long it has been there, what kind of surgery has been done, what has been the impact of surgery.
Yeah, plus whether the disc is already atrophic or not. I mean, the time duration between the papilledema and the diagnosis of the tumor and how soon was it operated?
Yeah, and I think maybe why this question is asked is maybe that somebody saw the patient and the surgery has been done and the vision has not improved. So do you now give a dismal picture to the patient, or do you say that, it will still take some time for it to improve? So I think it will depend upon, as what you said, Hema, will depend upon a lot of factors. I mean, what's the status of the disc? What's the current maybe OCT? What's the average RNFL? What's the visual field and all that? And then maybe you'll be able to tell the patient as to where it is going. If it's already a pale disc with a all red average RNFL, then you know that the prognosis for this patient is poor.
Dr. Deepak Bhatt is here. Can you hear me, Dr. Deepak Bhatt?
Yeah.
Dr. Deepak, you want to just quickly tell about that case, the pseudopapilledema drusen picture, and what is your role in B-scan for diagnosing papilledema, and OCT, role of OCT for papilledema?
Yeah, so that was a little tricky case that Hema had sent. And frankly, she must have shown you the slide. If you have a very frank drusen with a very high reflectivity or echogenicity, it's very easy. It's not a challenge for really anyone. But when you have a very subtle buried drusen or a drusen which is just over the surface, we frankly have to do a lot of manipulation or a lot of juggling around in the ultrasound machine, where we have to reduce the gains and increase the gains and be sure that we are dealing with a small drusen. Now, this particular case had a very small drusen, frankly, on its surface. It was not embedded, and if you had seen that picture, you could have seen it. And I saw it basically on reduced gains. It was not seen on normal gains. So that's my message, that just do not say that drusen is not present by doing a small ultrasound. Just put a probe there and this looks okay and it's fine. So that was the reason, and it is seen on ultrasound and not seen on anywhere else, primarily because of the size and primarily because of not seeing on a low gain.
And can you tell the B-scan signs of a papilledema?
Well, B-scan signs of papilledema, there won't be any, frankly, anything just apart from the elevated disc. The echogenicity will be very smooth. And the most important role, of course, is to rule out pseudopapilledema in the form of a drusen. So if you don't see any echogenicity over the entire extent of your edema and have the same echogenicity all throughout, even in high and low gain, yes, it is papilledema.
So then coming back to the, Rashmin, if Dr. Deepak Bhatt said that the drusen was very small on the surface of the disc, would that cause this kind of an elevation of the disc?
One, it will not cause elevation, and drusen on the surface of the disc is less likely to cause a visual field defect or a visual symptom than the buried drusen, because it's right there. So these are the two things which would go against any visual optic nerve dysfunction. And if it's just a small drusen on the surface of the disc, then you probably are looking at something else.
Okay.
Deepak, could I ask Deepak a question, Hema?
Yes.
Is Deepak there?
Yeah.
Deepak, is autofluorescence with the newer machines helpful in detecting these drusens? The newer machines, not the older version, if you have any?
Yes. They are helpful, especially the green autofluorescence, not the blue one. If you have the green one, it does pick up very subtle drusens much better. Sometimes in the little superior to B-scan also, if you have not done the B-scan properly. It does help. Yes, definitely it does help.
Any other questions, Swapnish? I've finished the questions that you've sent me.
One last question, madam.
Yeah.
Just hold on. There is a case scenario where a patient had established papilledema, no paler, and surgery was done within 2 days of diagnosis. But the diplopia persisted for around 2 months after surgery.
Yeah, I think this probably was the case which was discussed, and I would like to ask whether was there any ocular motility problem? Why patient is having diplopia?
I'll just unmute the participant. Anjali Khairnar, can you hear me? Anjali?
Yes, sir.
Yeah, can you ask your question to the panelists?
Yes, sir. Actually, the patient was a medical student and she had persistent headache since last 6 to 7 years. She came to my OPD with headache on that particular day, and I saw she had established papilledema with diplopia, and her vision was 6:9, 6:12. Right eye 6:9 and left eye was 6:12. And immediately she was shifted for the surgery. Within 2 days she got operated, but then later on I could not see her because she was persistent. That was the complaint which was persistent even after surgery for around 2 months.
No, so I think we need to find out why she was having diplopia. I would expect this patient to have some ocular motility problem if patient had a truly binocular diplopia. If patient had a monocular diplopia, then maybe there was something wrong with the eye. But if patient had a truly binocular diplopia, then we would find some kind of even minor visual field, the ocular motility defect, or even nystagmus. Sometimes, a lot of times, the oculopsia is being reported as double vision. So you would probably look at these things carefully and see if is there even a minor squint in all gazes. Do the one covetous and see if you're finding any squint anywhere.
So I would say check all the 9 gazes. Second is establish whether the diplopia is horizontal or vertical. If it is a vertical diplopia and you don't see any extraocular motility defect, it's most likely a superior oblique palsy.
Fourth nerve.
Yeah, fourth nerve. So that is something that you would keep in mind. But again, one needs to see the patient to actually understand why he has diplopia. And I'm sure it will settle. I mean, you don't need to be worried about the diplopia. It takes a little time, whatever the cause is, and usually settles over a period of time.
Yeah, so I would give between 3 to 6 months to say that even if you, let's say, patient had an ocular motility problem because of the tumor or because of the surgery, it should, unless there was a structural damage, long-standing structural damage, either because of the lesion or because of the surgery, then obviously you would, but then you would have seen some kind of obvious squint in those cases.
Yeah. Swapnish, any other questions, or should we?
No, ma'am.
Yeah. So should we wind up then?
Sure, madam.
So Preetham, do you want to give the?
Just unmute, sir.
So I think we'll conclude here. Sapnesh, you can mute, yeah. So I would like to thank all the the experts who were here, especially Dr. Azad from Jaslok Hospital. Thank you so much for being with us, sparing the time,
Thank you,
and helping us understand all these interesting cases of neuro-ophthalmology. Dr. Rashmin for his fantastic acumen and his knowledge. Thank you, Dr. Rashmin, for being with us. It's always a pleasure to have you with us. Dr. Phiroze Patel, sir, we want to hear you more often. Thank you for joining us. And Dr. Hemalini for a wonderful presentation. I thank everyone. And with this, we will end the meeting. The next meeting is going to be on Thursday, and that is going to be on uveitis. Also will be interesting. We have some interesting topics and some of our own members presenting interesting cases in uveitis. So please don't forget to join us on Thursday at 6 p.m. Sapnesh, anything else you want to say before you close?
I just wanted to congratulate you, madam. At one point, we had 200 participants.
Wow, fantastic.
Wonderful.
Sapnesh?
Yeah. So can I end the meeting, sir?
Yes, please do. Thank you very much. Thank you very much.
Thank you, sir. Thank you.
Bye.